also on phase where we have to extract the teeth. So I mentioned you have to mute the microphone, Nakas, otherwise I think, no?
Samish, you know all the time.
No. Okay, so you have a matching of all the, you remember all the digital data. This is a more recent case, so we use all the, the newer technology. So I will show you different stages, different things, and I'd show you the last one with its advantages. So we can match the laughing scan, implement the movements in the planning software, which this time is exocad. I suppose Christos will use the same. So we can match all this digital data, nevertheless manually. I mean, AI will play a very important role in the matching in the future. I will show you in a minute, but by now, in this case, was made manually. A comb CT. So in this phase, we plan the implant. And we also plan tooth by tooth rehabilitation. We keep 2-3 teeth to support the guide. You see in the upper jaw and in the lower jaw also. So we use a certain strategy to have a good stability of the guide. So this is the way you plan the implants. And this is also, there are topics which we have to talk into detail when we are in New York, how we plan it, what are anatomical parameters which are important to use, how do we do the guides, and which is important there in the moment of guided surgery. But probably until then you will know everything from Christos, I think. So now this is the provisional, and the provisional you can apply on the palate with that kind of palatal plate. There are many ways to fix the provisional also, and you can go for the surgery, which is really straightforward. The advantage of the system is, in this case, and I have to say, I used really many digital trays of many systems, and I'm able to do a comparison. And what happens mostly is that one system is copying the mistakes of the other, so which is not allowed to be happen. So this tray of the system, of the CTEC system, is really very simple, having taken all into consideration what the clinician needs. In some of the trays, you don't have enough multi-unit abutments to, not multi-unit, fixation abutments to fix the guide. So this is, and you have to order separately. So there are a lot of things that only the experience shows you. Well, nevertheless, this is the situation in the mouth, in the upper. This is the depth of the insertion. You see the aesthetic parameters of placement respected also in this case. And the multi-unit abutments. Since the implant has a more tapered conical connection, we always make the impression all on multi-unit abutments in order to fix that and not to have any vertical discrepancies. Okay, so as I said, we graft also with PRF the sockets, and this is the situation after the surgery. You have implants placed in the sinus area, which you don't load because you don't have the possibilities or the opportunities there. This is the provisional, and here is after the healing, the situation over multi-unit abutments, and the final, where we do an continuous scan strategy over the scan bodies. So in order to be able to do a scan over full arch, we splint the scan bodies in the inner side, or and the scan bodies has to be with a flat surface outside, so that the scan are not having jumping distance. In this way, and this is a study which we did with in full arch or multiple tooth or implants rehabilitation, has had a better success of the outcome by also a prosthetic success, passive fit restoration, and low incidence of complication.